that there is no regeneration in certain areas, particularly with the double arrows. And this occurs if there are no ducts, then you don't have any progenitor cells, or if the progenitor cells are not able to work. And I'll discuss that more. You will notice that in the areas where there is no regeneration, there is more collagen if you measure it as a concentration. So the concentration has increased because of the collapse. With time, bud-derived tissue develops from the progenitor cells, and it starts to fill in the defects in the map of the cirrhotic tissue. So this is bud-derived tissue, and you'll see in the area that was more severely involved, there is some duct proliferation, shown as little cluster of grapes, but there is no budding activity, and this I call an arrest of the bud sequence. Now I will show hepatocellular regeneration, which also occurs. Mature hepatocytes may regenerate somewhat, especially in near normal livers, but less in advanced disease. But you will see this nodule and others will enlarge. So there's some compensation there. And then here we have more bud-derived tissue in green. Now this cartoon may be surprising to you, and a year ago I would have been hesitant to show you this, but I've seen more examples that will convince you that this actually does happen. So here is a needle biopsy that shows this. You can see on the top right there is a septum. This extends to the left, but this septum is largely filled with bud-derived tissue. You can tell on the reticulin by the shape of the morphology. It's forming little rosettes. On the center photograph, you have the EpCAM stain, which shows you the recent progeny from the progenitor cells in brown in the same area. And also in the same area, you have the CK7 or CK19, shows prominent increase in these cells, which are equivalent to the canals of herring. So when you look a year later at that liver, these features that I've illustrated on the right are no longer visible, so the whole liver is now a homogeneous mass that looks almost normal with no septation. This is a very well regressed cirrhosis. You will note, however, that many of the hepatic veins are still obliterated, and I haven't discussed the portal veins at all. So these concepts suggest there are new parameters that have to be considered, and I will talk about each of these. One is the arterial density, which is increased throughout this liver, but especially in areas of severe arrest. And the second point is that the budding activity, or the arrest of budding, also tells you something about the prognosis. So how do these two parameters perform? First of all, here is an example. On the left is a normal liver with arteries just greater than 30 micron diameter, relatively large. On the right, you have cirrhosis, where you have a 6-fold increase in the number of arteries per unit area. Severe cirrhosis. Notice also that these arteries are entirely present in the septa and not in the nodules. This tells you that the regenerative nodules, which are coming from buds, are rising from very small arterial units, which are smaller than 30 microns. So we have evidence for regenerative activity, but only in very small arterial units. So if you look at a number of needle biopsies, you will see that you can correlate the artery density with stage across the bottom. And you'll notice that this high six-fold, roughly a 6 or 7-fold increase in red is found only in 4C and lesser degrees in the milder types of cirrhosis. But the CPA, which is our gold standard, I'll say it again, this is the gold standard for staging, is the collagen proportionate area, and it correlates exactly the same way. In other words, when you look at the artery density, you are also looking at the collapse, which has caused the increase in collagen concentration. Now, how does this perform? This is the CPA starting with patients with hepatitis B in this trial who were studied before and after entecavir, and you can see the CPA declines in most patients. The artery density performs almost as well without doing the Q fibrosis analysis. So here you can see I've added the artery density to the scale, and you can see it's virtually identical. The numbers are slightly different, but the percent change is the same. And this is a continuous variable, and you can use it mathematically the way you would use the CPA. It will also detect regression. Now let's look at the buds for a moment. On the left is a very active budding liver, which used to be a 4C, but is now probably a 4B or even a 4A, as the septa are filling in. This is the keratin stain showing all the budding activity, both in the septa and slightly more mature budding activity with this starry sky pattern. See these tiny dots represent single cells of keratin positivity. On the left, you have a liver which has failed to repopulate. It has arrest of the bud sequence. And you have these huge septa which have no keratin positivity. The only keratin positivity are these ducts that have proliferated, trying to make the buds, but they are arrested by presumably the ischemic milieu because the large hepatic veins are gone in this liver. So, to summarize, then, we need new staging systems. We are making progress with histologic evaluation. Pathologists just don't sit in a dark room. We have to worry about our image, and so we start with something new. So we are working on a LINEC 2020, which I like because the numbers are so obviously useful to indicate that it's so good. We will start with the LINEC system. That will be unchanged, but we have new criteria to increase the precision of its use. But in this new one, we will add new features that relate to artery density and budding, and probably several other things that I have not mentioned. So the first is a surrogate for the CPA. As I mentioned, is continuous, and if you don't want to do the CPA, just do the artery count. You can do it at the microscope with minimal training. If you're a pathologist, it helps to have a stain like the actin stain to find the arteries. The budding will assess regenerative activity and can also be expressed in a continuous variable, such as the total number of pixels that are keratin positive divided by the area. So I'll finish with this. I think we can always use a biopsy, and there are some obvious clinical reasons why you might want it. But the main one I'm interested in is that all the data that has been shown this morning comes from studies from the year 2000 to the year 2018 or 19. So they are all using old biopsy classifications, usually the Medivir, and it was developed and validated to give you recommendations which are now old. So if we have tissue, and you will need tissue, or you can restage your biopsies with a new classification with these extra advantages, you will then have new recommendations which will have increased precision and utility in the future. I acknowledge my colleagues both in China and in Halifax. Thank you very much for your attention.